Oh my gosh. Okay. Live on Facebook.
Yeah, you can see it already. Yes, so we are live
Yes.
on the Bed David's page. So I'm going to do a watch. Perfect. I'm not going to. I'm going to do a watch party. Start with friends. Just say yeah. And the Bed David's page. So I'm going to do a watch. Okay, so this watch party is not going to work because it's
Going to background noise.
yeah, it's going to give feedback. I'm going to do a watch party. Let's just say yeah. So others can do it, but not us.
So who will do it?
No, I won't do the watch party, but I'll just tag Wanjiku under Bed David's. Yeah, and people are commenting already.
I shared it as well.
Oh, good.
Oh my gosh.
Okay, we can start adding people. In Hi, welcome everyone. Yeah.
We just have one more minute and then I think we are ready to start. Well, it seems time is up. We had less than a minute. Good morning, good afternoon, good evening. Welcome to everyone that has taken their time to join us today on our webinar hosted by Beth Davids International. My name is Wanjiko Gishohi and I'll be your moderator for the day. Today's topic is especially interesting. It will be on nutrition in pregnancy and early childhood during the COVID-19 pandemic, and we'll specifically focus on challenges and recommendations. Of course, having in mind that it's a very wide topic and a lot could be discussed. And so we'll dwell on the highlights and hopefully have an interesting discussion after the two presenters talk. Like I said, we'll discuss various guidelines for optimal nutrition in pregnancy and early childhood. First, I'll just give a bit of housekeeping rules while we are having the webinar. In the chat box, feel free to introduce yourself and indicate your organization and or where you're joining us from in the chat box. It will be interesting to know the different people that have joined us today for these interesting discussions. And also as the presentations go on, feel free to type in your question and to whom it is directed to in the chat box. If it's to both speakers, then there's no need to indicate. And so I will throw in the question to both the presenters of the day. There are also those who are joining us via Facebook Live. Do also type in your questions and they shall be addressed within the 1 hour's period we have. If you have issues with connectivity, you could also try to remove your video and probably your connectivity will improve. And so you can be able to freely and seamlessly join us in the conversation today. In terms of who has registered for today, we have a wide and varied audience with us. They are nutritionists, of course, it being directly a topic related to health. They are dietitians, they are researchers, but they are also insurance professionals, they are early childhood development practitioners, of course, based on the topic. They are lawyers, business developers, microbiologists, people in the agriculture research sector, they are policy analysts and so on. And so this is particularly interesting to us because the three of us, or the speakers for today, will rightly point out that maternal and child nutrition is a multi-sectoral issue. And so it's very interesting that we have a varied audience. In terms of our presentation today and our discussion also, I would like to introduce our presenters for today. We have two presenters. We have Dr. Olusola Sotunde, who will be our first speaker. And she is a registered dietitian that has practiced in various capacities and specialties for over 18 years. She has a passion for maternal and child health and has greatly influenced her research so far. And she previously investigated the relationship between maternal health profile and weight gain in pregnancy on the viability of the pregnancy outcomes in Lagos Island Maternity Hospital in Lagos State, Nigeria. She also has worked as a postdoctoral researcher on nutrition in pregnancy and early development, assessing dietary intake and nutritional status of urban pregnant women in Johannesburg, and also Johannesburg in South Africa. She has equally investigated the long-term response of lean fat mass to vitamin D in interventions in neonates and paternal epigenetic inheritance, with emphasis on impact of nutritional status and dietary intake on the sperm epigenome and reproductive outcomes as a postdoc at McGill University in Canada. So Sola is presently the Senior Technical Advisor for the Nutrition and Health at Beth Davids International, and she's also an alumni of the esteemed African Nutrition Leadership Program, and might I add, the three of us also are. And she's also an enthusiastic advocate for the scaling up of nutrition-sensitive interventions for improved health outcomes of pregnant women, infants, children, and adults. So with that background, she's aptly placed to be a speaker today, and thank you, Sola. Katie will be our second presenter. I will just present her now so that then when we go into the presentations, we go there to it straight. Katie is a registered dietitian and has been working the field of public health nutrition for over 15 years. One of her areas of interest is the protection, promotion, and support of breastfeeding. She is currently completing her PhD in public health through the University of Western Cape on the maternity protection of non-standard employees and potential implications for breastfeeding. Katie has also worked for the Department of Health in South Africa for 8 years, on a global research project for 3 years, and in academia for 4 years. She's also an alumni, as was previously said, an alumni of the Africa Nutrition Leadership Program. So it's my great pleasure at this point to allow Shola to begin her presentation. Welcome, Shola, and please continue typing in your questions and comments and your introductions in the chat box. Thank you.
Thank you so much, Wanjiku, for that introduction, and welcome everyone. As Wanjiku has rightly said, I will be, I hope everyone can see my slides. Can I get a feedback from someone? I hope everyone can see my slides.
Hi, everyone. I actually can't see the slides. Oh, my name is Magabong Mduli. I'm a dietetic intern at UKZN. I was invited by my lecturer to be part of the Zoom meeting.
I can see the slides. Hello.
Okay, thank you so much. So I'll just get right into it. That's fine. I'll get right into it. So, okay, thank you everyone. And I'll be speaking on nutrition in pregnancy while Katie will be speaking about the early childhood. So the challenges and recommendation during COVID-19 pandemic. I just a second more because it seems my slide is hanging up a bit. Okay, I'll just quickly escape. So this is interesting. We spoke about the possibility of this happening, and then here it is. Okay, I'll just stop sharing for a bit and start up again and see if that actually solves the problem. Okay. Just a second to fix the technical difficulty we seem to be having right here. Okay, so we get right into it. A couple of us on this call, on this webinar, are aware of this modified micronutrients. Yeah, a couple of us are aware of this UNICEF. Just a second, something is happening to my slides over here and I need to just stop that. Okay. Okay, please, I really apologize for this. Just give me a second, please. Hello, everyone. I really appreciate, I'm sorry about that. That was a glitch that we didn't see coming. So I'll just quickly go over go straight to, this is interesting.
As Shola sorts out the slight technological hitch, I'd kindly ask everyone to, apart from the speakers and myself, to have their videos off, please. Thank you.
I'll see right away because we didn't seem to have this problem the other time. So I'm just wondering what is causing the problem right now. And we've tested this and there was nothing to this. Okay, I think we might have overcome it. Oh, perfect. So I'll just quickly run over the introductory slides. As I was saying about how a couple of us as nutritionists and dietitians and medical health professionals on this call are familiar with this conceptual framework from UNICEF, whereby food insecurity is an underlying cause for malnutrition, which actually also leads to inadequate dietary intake, which is actually an immediate cause for malnutrition. However, when we substitute that for maternal, or when we make it specific to maternal malnutrition, this has far-reaching effects, like such short-term consequences of maternal morbidity, maternal disability, or sadly, at times, even maternal mortality. And some of the long-term consequences include inability of the child that was born to reach the adult height, which we usually refer to as stunting, impaired cognitive development, which also leads to impaired economic productivity later in life, and then also has some intergenerational consequences. So when a pregnant woman is malnourished, there is a tendency, there might be, the woman might have anemia, especially if this is if this woman is iron deficient. This could also lead to maternal insulin resistance, which could lead to gestational diabetes mellitus, which will later predispose this pregnant woman to developing diabetes mellitus later in life. Some of the effects of consequences of malnutrition in pregnancy, like I said previously, pregnancy could be pregnancy loss, could be birth defects, could be intrauterine growth restriction. This could lead to having a preterm birth or even low birth weight. And on the effects on the child could actually be infant or child mortality. There could be impaired growth or body composition. There's been lots of research on this as well. There could be cardiometabolic or compromised cardiometabolic immune function, etc. So when we're talking about nutrition recommendations to support healthy pregnancy, for instance, energy recommendation is actually based on a variety of factors, which include the age of the pregnant woman, the pre-pregnancy body weight, the pregnancy trimester, whether it's the first, the second, or third trimester, the goal of the weight that the pregnant woman is supposed to gain, the ideal weight gain for pregnancy, whether this woman is carrying a singleton or a multiple birth or multiple fetuses, or if there are presence of pregnancy comorbidities. And for other macronutrients, apart from energy, other macronutrients are pretty stable. They are practically the same. It doesn't change based on all these factors or scenarios that I painted earlier. For micronutrient intake in pregnancy, this is particularly important for pregnant women because there is an increased need for both the mother and the fetus. Thereby, a pregnant woman is supposed to have higher intake of these micronutrients. And a couple of us are aware of iron, the importance of iron and folate supplementation in pregnancy. However, there is lots of research also to speak of the effect of why there is a need for other micronutrients to be included as supplements, because there's been several reviews of data from several studies on the importance and functions of these micronutrients, right from even before conception. And research is emerging to show that it's not just even for the mother as well. Even the nutritional status of the father actually has an intergenerational effect on the neonates to come. So as nutritionists and dietitians, this is what we would like to see for a pregnant woman to be able to, at a go in a seating, to be able to have all this in this proportion in a plate. However, this is not usually the case, as we all know, as we've all seen. So there are measures to make sure that the micronutrients, the increase in micronutrients, the need for the increased micronutrients that this pregnant women need are actually provided either through food fortification or through micronutrient supplementation, which could be iron folic acid supplementation or multiple micronutrient supplementation. So the WHO, UNICEF, and World Food Program actually did a composition of what should be in the multiple micronutrient supplement for pregnant women in emergency situations. And like we know, COVID-19 has become, the COVID-19 pandemic has become sort of an emergency situation worldwide, whereby this multiple micronutrient supplement is supposed to be taken by the pregnant woman once a day to make sure that she gets all she needs for both herself and the infant. So I looked at some of the benefits of studies that have looked at the benefits of multiple micronutrient supplementation, comparing it to iron folic acid supplements. And in 2017, Smith and colleague did a meta-analysis of 17 randomized control trials, looking at multiple micronutrient supplementation versus iron folic acid in 14 low income and middle income countries. And what they found was MMS provided significant greater reduction in neonatal mortality, especially for the female neonates, compared to the males, compared to those on iron folic acid supplements. Also, there was greater reduction in low birth weight, small for gestational age birth, and 6-month mortality in anemic pregnant women. In 2008, there was a summit study that was carried out in Indonesia on over 30,000 pregnant women, and to look at and this they were about half of these women were supplemented with iron folic acid, while the other half were supplemented with multiple micronutrient supplements. And infants of women consuming multiple micronutrient supplements had an 18% reduction in early infant mortality compared with those who were given iron folic acid supplements. Also, when they look at when these children were weighed within 1 hour of birth, there was a 14% decrease in risk of low birth weight for those in the multiple micronutrient supplementation group compared to those on iron folic acid, especially for women who were anemic at enrollment. There was a follow-up to this summit study in 2017, whereby this infants born to this women that were supplemented were followed up at between the ages of 9 and 12, and to check on what the effect of multiple micronutrient supplements is on their general intellectual ability, their memory, executive function, and academic achievements. And the results showed that children of mothers given multiple micronutrient supplements had a mean score higher in procedural memory than those given iron folic acid supplements. Also, children of anemic mothers in the MMS group scored higher in general intellectual ability, which is similar to the increase with 1 year of schooling. So with all this in mind, because like Wanjiku said in the introduction, on this webinar today, we have policy analysts, we have people that have the ears of leaders in government. What does this mean? How do we translate this to make sure that it benefits the people that needs it the most? So Nutrition International has a cost benefit tool online. So I went there to go check out for 3 countries, maybe I'm being partial because the 3 countries that I looked at are Nigeria, Kenya, and South Africa, because those are the 3 speakers for today. So, and using the assumption based on the population of Nigeria, the cost of supplementing all pregnant women right now with iron folic acid, or even if it's just 30% of those pregnant women that are supplemented with either iron folic acid, and the costs of supplementing them with MMS. And what I saw was, if we transition, for instance, if Nigeria transitions from supplementing pregnant women with iron folic acid to giving them multiple micronutrient supplements, this will avert an additional 3.5 million dailies, which will avert an additional 3.5 million dailies. And also it will prevent the death of additional 50,000 children. And this is the goal. We want to make sure that we don't lose mothers, we don't lose children just because the mother got pregnant. And the trend is similar for Kenya. If Kenya transitions from IFAS to MMS, there will be an aversion of an additional 375,000 DALIs, and also additional version of over 4,905 death of 5 children will be averted. Similar for South Africa as well. So why all this? Because in May this year, Robertson and colleague actually did a modeling study where they looked at the indirect effect of COVID-19 pandemic, and they looked at it specifically on maternal and child mortality in low income and middle income countries. So they looked at 118 countries, and it was projected. This is not, like the author said, which I really like, this is not something they are projecting that will happen. But if the worst, looking at it from the moderate case scenario to the worst case scenario, if coverage of essential maternal health services, including routine healthcare and access to food, if it's reduced in these countries, we will be looking at, on a monthly basis, an additional deaths in the worst case scenario of about 9,000, close to 9,500 pregnant women will die. And out of this, about 361 of them will die just because they have no access to to micronutrient supplements. And this is not something we want, because a death of a woman, it's too much, not to now talk of having 100 and something die or 300 and something die, or getting to the extent of 9,000. So what are the risk factors that are causing for maternal undernutrition in the context of COVID-19, as we've seen? So there are basic factors could be things that we did not think about, but then that we have seen happening. Policy diversion to urgent care. So when policymakers are diverting the resources, so for instance, when policymakers are diverting nutrition professionals, dietitians to maybe doing contact tracing for COVID and all, and nobody is covering what should have been the maternal provision of education for nutrition education for pregnant women and all the likes. This becomes underlying, this becomes risk factors for maternal undernutrition in the context of COVID. If there is limited or interrupted food supply chain, which we've seen a lot, then this drives food insecurity, which also leads to maternal malnutrition. When there is reduced care seeking, when women are afraid that if they go to the hospital, which it's natural, or it makes sense, when if they go to the hospital without being sick, they might likely contact COVID-19. However, when they do not have access or alternative access to the information they should have gotten there, or to the supplement that they will have gotten there, then this actually becomes an underlying risk for compromised maternal and child nutrition. Also, now that education is also interrupted for even a girl child, and for instance, if we look at areas that have teenage pregnancies, because the teenagers in these areas are actually married or not, and they do not have access, especially for first-time pregnant women. They do not have access to knowing what they should eat during pregnancy, knowing this, having access to the supplements. This puts them in compromised states, and which is not something we want. And something we've known from all along is these are barriers to optimal diet in pregnancy, economic constraints. And this is something that COVID-19 has actually exaggerated, because a lot of people some people are losing their sources of income. Some people are having reduced income. And this has become a barrier for optimal diet in pregnancy. Intra-household food allocation, it's one that has been spoken about so many times.
This one?
Intra-household food allocation, like in so many areas, so many communities, we know that the woman of the house prioritizes serving the husband and the children before she gets to feed herself. And this is a barrier in pregnancy. Advice provided by key influencers on diet during pregnancy. So in this at this point, I'm speaking to the mothers, the mothers-in-laws, the fathers-in-laws, and even the husbands on this webinar today, that make sure you are not, your advice is not contradicting the advice that she's been given at the hospital about her diet. Because so many times researchers have shown that these women, even though they know and they understand, but just to honor or to revere the person who told them not to eat this because it's bad for their baby based on their own experience, they tend to follow such advice at the detriment of their own health and that of the growing fetus in them. Also, knowledge and belief about optimal diet during pregnancy, food the woman considers to be unhealthy, food avoidance, if a woman is avoiding a particular food because the taboo says, the cultural taboo says a pregnant woman is not supposed to have eggs so that the head of the baby is not too big and she has difficult childbirth experience, which are usually not the case. Pre-pregnancy food consumption patterns. It's also been shown that people don't basically change their food consumption patterns. So what a woman is used to eating or not eating before she gets pregnant, there is every tendency to continue that way. Also, missed opportunities for maternal dietary counseling during antenatal care. So this is one of the things that we spoke about when a mother is does not have access to dietary counseling during antenatal care, and this is something also that has become exaggerated during this COVID-19 pandemic. And this sets us to what can we do? How can we make sure that everything we've gained, all the trajectory that we've moved upwards on before COVID-19 pandemic started, we don't want to lose focus. We don't want to lose that. So the recommendation recommendation is provision of food insecurity interventions, provision of social protection programs, providing access to healthcare. And I just want to state something here. It's political buy-in is very key, and this is why we're trying to reach out to all our policymakers as much as possible to make sure that we don't just focus on the COVID-19 pandemic, but also not forget the importance leveraging on focusing investment in maternal and child health services through already the existing health service system that we have at hand. So there was a joint statement by WHO, FAO, World Food Program in April for Asia and the Pacific on recommendations for reducing maternal malnutrition while we're battling COVID-19. So one of them is continued nutrition counseling on the mother's diet with appropriate infection control measures, prioritizing social protection measures to safeguard the diets of pregnant women, also providing alternative strategies for counseling and advice on feeding diets and nutrition for pregnant women. So this is to get us thinking. If I cannot, so a couple of us have been fortunate enough that we can work from home. Can we also provide these important services to these pregnant women from home where they feel safe? Can we provide telephone and online counseling or advice? And to reach women who don't have access to telephone or access to internet data, can we do radio programs to make sure that we keep this conversation alive, we keep it going, and we keep these mothers, we do not lose any to just because it's something that happened as they become collateral damage for COVID-19. Continued provision of nutrition services for iron, folic acid supplements or multiple micronutrient supplements, providing alternative distribution methods for supplements if these services can be conducted under safe conditions while we maintain the physical distance measures. And these are the things that I would like to leave with us today to say we cannot just say because something has been disrupted, then life does not continue. We know for a fact that people are still getting pregnant, but we need to keep taking care of them the way we know how to do. I'll think about how do we do it in a better way. Thank you.
Thank you very much, Dr. Shola, for your presentation. I think you have done a good job of highlighting the recommendations, the benefits of multiple micronutrient supplementation, even nationally, what that would mean in terms of lives saved and disability-adjusted life years. I think even further, what was important is how you showed how COVID-19 has further exacerbated the challenges that were already there in terms of ensuring that recommendations are followed. And it formed a good segue to have Katie now present on the recommendations, what challenges she has observed from her work, and also what recommendations would be given in such settings. So you're welcome, Katie, to take the floor. While Katie's setting up, just to add that if you have any questions, feel free to type them in the chat box, and we will discuss them as we go on. Is Katie, can you see Katie's slides?
There, sorry, I was muted. Can you see my slides now?
I can see the slides.
Okay, sorry about that. Okay, so good afternoon and good morning, everybody. And as Wanjiku mentioned, I'll be presenting the second section on challenges and recommendations of nutrition in early childhood during the COVID-19 pandemic. Also having technical challenges now with moving my slides. There we go. So just as a disclaimer, I could probably spend the whole day or afternoons discussing infant and young child feeding and the impacts of the COVID-19 pandemic. But the purpose of this presentation is to provide a bit of a snapshot of some of the latest recommendations and share some of the many resources that are available on this topic. So this presentation will be shared with everybody afterwards with all of the web links and references that we've included, and that will be shared with everyone. So essentially today, between Shola and myself, we're discussing the nutrition during the first 1,000 days, which is the time from conception until a child reaches 2 years of age, and provides unique opportunities for your health and nutrition. And these are two examples. The first image that I showed was from the first 1,000 days website of the Western Cape government in South Africa. And the second image is the 1,000 days international NGO that both have large amounts of resources and information available, including updates on recommendations during the COVID-19 pandemic. So for those who aren't familiar with the first 1,000 days, this refers to the 3 life stages of pregnancy, which makes up approximately 9 months, which is about 270 days. The first year of life or infancy, which is birth to a year. And then the second year of life or early childhood, which is 1 to 2 years. And the reason why we speak about this is because nutrition and health is important in the first 1,000 days. And nutrition plays a really important role in achieving optimal growth and development in each of these 3 life stages. And we've got what we refer to as critical periods of growth and development, where specific and sufficient nutrients are required for optimal growth and development to take place. And if these nutrients aren't available, or if there are adverse health effects such as smoking or illness, this can lead to deficits which can have irreversible implications in the short term and the long term. So the first 1,000 days is often referred to as the brain's window of opportunity. And the reason for this is because the human brain develops and changes throughout the life cycle, but the period of growth is most rapid during the first 1,000 days. This means that the number of cells in the brains increases, there's growth and differentiation, and there's connectivity between the brain cells. And deprivation during this time can have long-term effects, but also intervening this time can partially correct some of the damage that might be caused during this time. And this is why we like to focus on this first 1,000 days. And as I mentioned, I'll be focusing on the early childhood section. So optimal nutrition during early childhood is defined as the early initiation of breastfeeding, starting of breastfeeding within 1 hour of birth, and then exclusively breastfeeding, providing nothing else besides breast milk up until 6 months of age, together with the introduction of adequate, appropriate, and safe complementary foods from 6 months, but with continued breastfeeding up until 2 years and beyond. And optimal nutrition in early childhood is important because each life stage, the nutritional status and health of one life stage can influence the health status in a life stage. And meeting health and nutrition needs at every life stage of the life cycle is important for disease prevention and health promotion. So an example is, as Shola kind of alluded to this with in her presentation, but something like undernutrition during pregnancy can actually program certain genes that lead to an increased risk of chronic non-communicable diseases later on in life. A second example is iron deficiency in young children can lead to decreased intellectual capacity later on in life, or is associated with that. And this next slide shows a diagram that was developed by the World Health Organization and colleagues, and shows various stages of the life cycle of women, children, and adolescent females where nutrition can be ensured to enable optimal health. And almost half of this diagram covers what we're speaking about today, which is nutrition during pregnancy, during infancy, the first month, the first year, and up until 2 years, and early childhood often extends up until 5 years as well. So what I would like to speak about are 3 main challenges that have come up with regards to infant and young child feeding during the COVID pandemic, and some potential solutions or recommendations regarding these challenges. So the first is that infant and young child feeding, and therefore infant and young child nutrition, can deteriorate during any pandemic. But the good news is that we've had pandemics before, and we have not that that's good news, but we have guidelines on infant feeding during emergency situations, which I'll introduce you to. The second challenge is that COVID is a novel or new disease, and there's conflicting information that's being shared, which is confusing to both consumers and mothers and health professionals alike. So mixed messages are being shared. But the World Health Organization, UNICEF, the World Food Programme, many international and national organizations are constantly sharing updates on balancing the risks and benefits of various practices. This is part of our challenge, and I found it particularly challenging to try to keep up to date with all of this new information that's being shared on a daily basis. And then thirdly, what I'd like to address in this presentation is when we start looking at the introduction of solids and complementary feeding, we're seeing increased reports of households experiencing hunger and food insecurity, and this will definitely have a negative impact on complementary feeding. And in order to address that, we need to look back at what Shola mentioned regarding the different levels of factors that influence malnutrition. So in food insecurity, decreased employment, decreased economic access to food, and follow optimal infant and young child feeding recommendations that have been provided. So firstly, the influence of the pandemic on infant and young child feeding and infant and young child nutrition. As Shola mentioned, resources get redirected towards the pandemic. So these might be financial resources or health worker resources, as Shola described. And related to nutrition and infant and young child feeding, important services like growth monitoring and promotion, health promotion and nutrition education on breastfeeding, appropriate infant and young child feeding might not be routinely done because, as Shola mentioned, services are interrupted, but also mothers might be fearful of coming to facilities due to the increased risk of acquiring the infection. And then what we also start seeing is relief efforts being initiated, and sometimes these are initiated by people with limited nutrition and health knowledge, although their intentions are very good, but they might not be aware of the guidelines that we have available and certain rules and regulations that are in place. So when it comes to, and then also we have the challenge that certain companies, food producers and breast milk substitute manufacturers might use the crisis to market their products in the form of donating foods. So when it comes to infant and young child feeding during emergencies, in 2017, a group called the Infant Feeding in Emergencies Core Group, the Emergency Nutrition Network and UNICEF put together operational guidance for infant feeding during emergencies, which aimed to provide practical guidance on how to ensure appropriate infant and young child feeding in emergencies. And the target group was infants and young children up until the age of 2 years and pregnant and breastfeeding women. And this guidance has various sections, but I just want to highlight section 5, which talks about the protection, promotion, and support of optimal infant and young child feeding, together with integrated multi-sector interventions, which, as Shola mentioned, is especially important to ensure that nutrition-sensitive and nutrition-specific interventions are being implemented. And then these guidelines also have a section on minimizing the risk of artificial feeding, because in previous pandemics, it's been noted that sometimes breast milk substitutes are provided as donations during emergencies. So there's guidance on how this should or shouldn't be done, how artificial feeding should be managed, and that if breast milk substitutes are needed, they should be procured together with appropriate safe feeding equipment and support to caregivers to be able to provide the breast milk substitute. And all of this needs to be based on the principles of the World Health Organization International Code of Marketing of Breast Milk Substitutes, as well as subsequent World Health Assembly resolutions. So quite early on in the COVID pandemic, so this was the end of March already, UNICEF issued a response to COVID-19 technical notes on donations and financial or in-kind contributions from food and beverage companies. And I just want to highlight the part related to infant and young child feeding, where the recommendation was that donations of breast milk substitutes and accompanying products should not be sought for or accepted for targeted or blanket distribution, and that donation of breast milk substitutes by manufacturers has been shown to increase its use and therefore reduce breastfeeding. and that in circumstances where breast milk substitutes are required, so it's not saying that breast milk substitutes cannot be given, but when they are required, they should be purchased, distributed, and used according to strict criteria. And these strict criteria are quite clearly clarified in World Health Assembly resolutions. And the most important point is it says that breast milk substitutes should be purchased and not donated. And then this technical note that was shared in March also stated that the operational guidance for infant feeding in emergencies, which I shared earlier, can be sought for more information. So in saying all of this, have we seen problems with companies trying to market products during the pandemic? Yes, we have. So at the end of June, this is an example of a piece that was published in the South African media, but actually shared examples of other countries where companies had used social media to either market their products by saying that they were donating products or providing information on infant and young child feeding or infant and young child nutrition that's either not in a compliance with the international code or violates countries' national legislation. So this does happen, and this is recent, what we're seeing in the media and on social media. So then the next topic that I'd wanted to speak about is the fact that there's all this conflicting information being shared. And as I mentioned, that even today, I was still reading up on updated guidelines and information and technical briefs and scientific notes being shared on COVID-19 and various nutrition-related topics. So we do have recommendations, and I think the World Health Organization and UNICEF and other UN agencies and NGOs internationally and national governments have been quite quick with sharing updated guidance and recommendations. And again, at the beginning of the coronavirus epidemic, the UNICEF, the Global Nutrition Cluster, and the Global Technical Assistance Mechanism for Nutrition shared some key messages and priorities regarding infant and young child feeding, together with useful guidance, resources, and references. And as I mentioned, the links to all of these documents will be shared when the presentations are shared after the webinar. And specifically, one of the messages in this document was that the code needs to be adhered to, but also it considered delivering infant and young child feeding services through various platforms, including households, the food system, the health system, water, sanitation, and hygiene, which has become very important with COVID, and social protection. And we've seen examples of this in different countries. And again, this document provided quite a number of useful resources and guidance and references. But even though we have all of this scientific information and credible sources, we've still seen instances where mothers and infants have been separated if the mother tested positive for coronavirus. And also we've heard of situations where mothers have been advised not to breastfeed because there might be a suspicion that breast milk could be transferred, that coronavirus could be transferred in breast milk. And we need to make sure that we are all sharing the same guidance. And as I mentioned, the World Health Organization and UNICEF has published numerous recommendations on pregnancy, childbirth, breastfeeding, and COVID-19. So before, during, and after childbirth, all women have the right to high quality care. Close contact and early exclusive breastfeeding helps all infants to thrive, and women should be, even with COVID-19, should be supported to breastfeed safely, holding her newborn baby skin to skin contact and sharing a room with her baby. If a woman is COVID-19 positive and wants to breastfeed, she needs to practice respiratory hygiene and wear a mask. She needs to wash her hands before and after touching the baby and routinely clean and disinfect surfaces, so routine infection and prevention control. And breastfeeding is particularly effective because we know that breast milk produces antibodies from the mother's immune system that then gets transferred to the infant. So if a mother is COVID-19 positive, the antibodies that she is producing will be transferred to the infant and increase the protection of the infant against coronavirus. In the certain situations, which is the minority, where a woman might be too unwell to breastfeed, there are other ways and other solutions where she can safely provide her baby with breast milk. And this includes expressing the milk and allowing someone else to cup feed the baby. If a mother has stopped breastfeeding because she was too ill, she can be supported to successfully relactate. And this often requires specialized support from a lactation consultant or adequately trained nurse or breastfeeding peer counselor. And then we also have the option of donor human milk. And there's a lot of advocacy for mothers who are able to donate breast milk for infants that aren't able to receive breast milk from their mothers, either temporarily or in the long term. And then at the end of June, the latest scientific brief from the World Health Organization stated that based on available evidence, the World Health Organization recommendations on the initiation and continued breastfeeding of infants and young children also apply to mothers with suspected or confirmed COVID, and that at present there is not data to show that COVID is vertically transmitted from mothers to infants through breastfeeding. This brief further went on to state that in infants, the risk of COVID infection is low. And we know that in infants and young children, infection is typically mild and asymptomatic, but actually the consequences of not breastfeeding or of separating the mother and the child can be significant. So at this point, the recommendations are that COVID-19 in infants and young children poses a much lower threat to survival and health than any infections that breastfeeding protects against. And therefore, the benefits of breastfeeding and nurturing the mother-infant interaction to prevent infections and to promote health and development are especially important when health and other community services are interrupted or limited, as we've mentioned. So adherence to infection prevention and control measures is important to prevent contact transmission between a COVID suspected or confirmed mother and her newborn or infant. So I think it's quite clear what the guidance is regarding breastfeeding and optimal infant and young child feeding for mothers who are COVID positive suspected, and remembering that at the moment, the majority of pregnant and breastfeeding women are actually do not have coronavirus, COVID negative. And the last point I'd just like to speak a little bit about is the fact that we are seeing increased numbers of households experiencing hunger and food insecurity. And this does have implications for complementary feeding. And again, I'm taking an example from a South African media outlet that just last week published a piece with the headline, "Children are eating wild plants to survive as hunger explodes." And this came from the National Income Dynamics Survey, which is a survey that's routinely done in South Africa, together with a new survey, the Coronavirus Rapid Mobile Survey, which was conducted with about 7,000 people. And this showed that hunger doubled during the lockdown period, and that 1 in 3 of those people who were earning an income in February were not earning an income in April. And women and lower paid workers were the biggest number of people affected. These reports also showed an increased demand for food parcels, for food aid, the fact that donors are running out of money, and that adults are attempting to shield children from hunger where possible. If we look at the international situation, last week, the State of Food Security and Nutrition in the World report was released, and this is focusing on transforming food systems for affordable, healthy diets, and has a higher level of accuracy of hunger statistics based on new information. It's also got a section that gives a preliminary assessment of COVID-19's impact on food security based on recent global economic outlooks. And it has projections of the number of undernourished people we expect to see by 2030, so which is when we are trying to reach the Sustainable Development Goal targets if recent trends continue. So what does this mean for complementary feeding during the time of COVID? So we know that before COVID, child malnutrition and inadequate complementary feeding was a problem. And the additional challenges posed by COVID are the disruption of routine services, the increased risk of acute undernutrition, which we refer to as wasting, a low weight for height or weight for length. And this increased risk of malnutrition increases the susceptibility to infection. But also, children rely on caregivers for their food and nutrition needs to be met. And if the caregiver is sick, then access to nutritious, safe food and drinking water could also be compromised. So the optimal infant and young child feeding recommendations remain the same: to continue breastfeeding up until 2 years of age and beyond, and for complementary feeding to start at 6 months, that breastfeeding should be combined with safe, age-appropriate feeding of solid, semi-solid, and soft foods. And it's really important to note that breast milk remains an important source of energy and nutrients in children, even up until the age of 6 months and beyond, up until 2 years and beyond. From 6 months to 12 months, breast milk can provide up to half of a child's energy needs. And from 12 months to 2 years, breast milk can provide up to a third of a child's energy needs. So during this time when households are experiencing food insecurity, breast milk can actually help to reduce the impact of that by ensuring an amount of food security and nutrition security for infants and young children. And also when a child is ill, breast milk is an important source of energy and nutrients for all children and reduces mortality amongst children who are malnourished. I mentioned wasting because wasting is the undernutrition that we see, particularly during acute undernutrition. And UNICEF and the World Food Programme have shared recommendations regarding the prevention and treatment of wasting. And this also adds on to some of the previous recommendations I've mentioned, to intensify programs to protect, promote, and support optimal infant and young child feeding and hygiene, particularly aimed at mothers who have confirmed or suspected COVID or are isolated at home, to support full compliance with the code, and to ensure that current nutrition programming reduces infection by ensuring that all staff and caregivers hand wash, that they physically distance, and that there's intensive messaging and communication to the community that is consistent and up to the latest scientific evidence. And to intensify efforts to strengthen the capacity of caregivers to detect and monitor their child's own nutritional status, for example, using something like the mid-upper arm circumference. And then also to intensify pre-positioning of essential commodities. So if there are children and infants who are needing therapeutic, ready-to-use foods or ready-to-use supplements, that they have a sufficient supply and a buffer stock that they don't run out. So lastly, I just want to highlight, I can't go into all of these documents, but as early as April, the United Nations issued a policy brief on the impact of COVID-19 on children. And again, this link will be shared, so you'll be able to access all of these documents. The World Food Programme has additional recommendations for the management of maternal and child malnutrition in the context of COVID-19. And then the World Health Organization, UNICEF, and the World Bank in 2018 already developed a framework for helping children to survive and thrive during the early childhood development phase. And you'll see that adequate nutrition forms a key part of this framework. And on their website now, they've got a number of links related to COVID-19 and early childhood development. And then lastly, there's a group called the Early Childhood Development Action Network that also has a huge number of resources on early childhood development during COVID-19. So just in conclusion, I'd just like to summarize that we need to be aware of the risks to nutrition and health of infants and young children during any pandemic, but particularly now the pandemic that we're facing being COVID-19. That current evidence supports the benefits of breastfeeding and mother-infant contact, outweighing any negative risks posed by COVID-19, remembering to bear in mind the infection, prevention, and control measures. And that we need to address all levels of factors influencing malnutrition. As Shola mentioned, the immediate factors, inadequate dietary intake and increased nutrient requirements, the underlying factors such as inadequate household food security, access to healthcare facilities, hygiene and sanitation, and then basic factors as well. And these all need to be addressed in order to ensure optimal infant and young child feeding during and following the COVID-19 pandemic. So I think my time is up. Thank you for your attention, and Wanjiko, I'll hand back to you to facilitate questions and answers.
Right. Thank you, Katie, for your elaborate presentation, giving us a connection between micronutrient supplementation and adequacy during pregnancy and early childhood. So you made that good connection where it starts from the pregnant mother and then goes to have benefits on later in life. but also that you've given a varied wide of resources that different practitioners that are online can access from the WHO, from the different agencies of the UN, from FAO. You mentioned even about this, the recently released State of Food Security and Nutrition report, and from the development network group that you talked about for early childhood. So thank you for those resources. I think I've seen a few questions, and I think one of the things as both of you are presenting, I was thinking about is, and that could be coming in the minds of the people that were presenting, is that there are all these recommendations and that we should go on with the normal, whatever we had in place previously to be able to ensure that mothers are adequate in nutrients and all that. But for example, one of the questions that I had, and also one of our participants has asked, specifically, let me check her name, Esther asked, is how do we ensure that our pregnant mothers are still, accessing prenatal services as they should, and this is both to you, Katie, and Shola, in a practical sense, because what we know is there's probably, and I recently listened to that, is there's a dip, and there's a fear that there's going to be a dip in the uptake of immunization and all those other nutrition specific services that are related to nutrition and health, especially because we have the COVID-19 pandemic and the physical distancing recommendation. So how do we ensure that our mothers still access these services? What practical action can be taken for mothers to still access that? I'll just throw in a second question so that you can answer both three questions at the same time. I think maybe this can specifically go to Shola from Gertrude. She asked, can a pregnant mother pass on COVID-19 to their unborn baby? Maybe also Katie would have a response to that, since she mentioned something around COVID-19 breastfeeding and so on. And the last question, that will be a good segue for Martin to come in with some comments. I hope Martin is preparing, is for the recommendations for multiple micronutrient supplementation. I think Shola went through this, but maybe it would be worth repeating. Is it practical? Is it affordable in a development country setting? So let's start with those and then see how it goes. I would like to beg the indulgence of our participants. We had a technical glitch, so we might go on over for 5 to 10 minutes, depending on the interaction. So over to you, Katie and Shola, to answer the questions.
Thank you. So I'll start from the last one, that was the question that was asked about how sustainable is it for low middle income countries to transition from iron folic acid supplements to multiple micronutrient supplements. And I will use Nigeria as a case study from one of the things that I presented. For instance, if Nigeria invests additional $25 million, which sounds like a lot of money, in transitioning from iron folic acid supplement to multiple micronutrient supplements, the benefits far outweigh the cost, because at the end of the day, Nigeria will be saving $30 billion for value of DALIs averted. And this is a big deal, because it is highly cost effective in that instance. Also, multiple micronutrient supplements is over 1,000 times more cost effective. So if we look at it, it's also the same way. Nothing good comes easy. If we look at it based from the immediate cost, and we do not look at what it transitions to eventually, we tend to lose more than we believe we're gaining. So this is a place where I spoke about getting political buy-ins, because these are the conversations and we want people to have. These are the conversations we want to have with our government, showing the statistics to say these are the benefits we can derive from this. Then Esther asked about practical questions, the practicality of what can we do, practical step. And to answer this very well, I'm going to crave the indulgence of Martin to share with us his experience, because Martin is involved in implementation of supplement trials in pregnant women in Malawi. But like something that comes to mind will be use of, for instance, if we're making it specific to nutrition services, use of radios to far to reach places to keep this conversation alive, to keep. So for instance, you could have nutrition professionals, you could have healthcare professionals come on radio, because there at least you can maintain we can maintain all the necessary interventions that we need to maintain to ensure that we don't get infected, and we can pass this message across to lots of people that might not have access to it. And then in places where you provide services, in cities whereby we have access to our participants' telephones, and they have telephones, we could also talk to them. It could become a telephone conversation. We could also use this kind of avenue, the online one, because the assumption usually so many times is that a lot of people do not have access to this. But then the reality is a lot of people have access to Facebook. A lot of people have access to social media. And a lot of people that never heard of Zoom previously now do. We can think outside the box and think of, even if it's to reach the community leaders who reach the people in their bubbles. Those are the steps that we can actually take. I cannot remember if there is any other question that I haven't touched on, but Katie, would you had anything to, yeah.
Yeah, thank you, Shola. Yeah, I totally agree with you. And I was going to say a similar thing regarding practical actions for mothers to access services. Whenever we speak to policyholders or the people who are funding programs, and as we see in the media, when we have a pandemic like this, at the end of the day, the bottom line is always about money. And the fact that money needs to be redirected towards the emergency response and to the pandemic. But we need to also remember that we have a lot of research to show cost-effective nutrition interventions. And that if we look at the cost-benefit ratio, so I saw one of the questions on the chat was, would it not be expensive to ensure that mothers are receiving adequate food? But if we consider the cost of ensuring safe, nutritious food or food supplements to a mother, that's much more cost effective than trying to provide a breast milk substitute to an infant. And so it's again this, and the fact that if we ensure that the mother is receiving adequate food and she can breastfeed her child, we're ensuring food security of 2 members of the household, and as opposed to just one. So one of the reasons for this webinar was to create awareness around the routine nutrition interventions that need to be continued and that we are unfortunately seeing being interrupted due to the pandemic and the emergency response, and the fear of people accessing services for fear of contracting coronavirus. And as Shola mentioned, trying to find ways of using virtual platforms to access each other, healthcare workers, other sectors, and to mothers and consumers as well. Wanjiko, you also asked a question about the transfer of coronavirus from mother to baby. I'm not 100% sure if the research has been established on during pregnancy, but as I mentioned in my presentation, there's currently no data to show that a mother will pass COVID to a baby through breast milk, but the recommendations are that she practices appropriate respiratory hygiene while breastfeeding and other infection prevention and control measures.
Well, I don't know whether Wanjiko, you want me to come in now. My apologies, I'm in the field, so I will not put on my video due to bandwidth, so that people can be able at least to hear me continuously. First of all, very good presentations. I really enjoyed all the clear presenters. This is really timely. And you're presenting things that we are experiencing right now on the ground. It's crazy what is going on. And so I'm just going to quickly answer or rather provide my input on what we are trying to do on the ground. I'm currently in Malawi, in the southern Malawi, a very remote region. Some of the programs we are running are in the Zomba Blantyre area, and the others are in the Rift Valley of Malawi in an area called Chikowa, very hot. malaria endemic region. In one of the programs, we are targeting to serve over 2,200 children and between 6 months to 18 months. And in the other programs, we are serving pregnant mothers and their newborn babies, and we are following them up till 1 year postpartum. And we just got funding to be able to follow up these children actually for the first 8 to 10 years of their life. So the biggest challenge we have is to do with personnel in relation to the vulnerable groups. Pregnant mothers and newborn babies are always vulnerable, as we know in nutrition. The challenge we have now is that the policy framework does not really cater for COVID-19 response. Malawi is just starting to respond to COVID-19 response. And we are starting to see situations where some of even our staff are getting COVID positive. And then suddenly they have to isolate themselves. So you have a whole, manager suddenly isolating himself because he is sick, or you have a whole teammate who was serving a whole team now suddenly not reachable because, well, they're sick, you can't force them to work. That becomes a real challenge. And so some of the things that we have done on the ground, which I can share with us, is we have segmented our teams. Whoever can work from home is being requested to work from home. And these are people who, for example, can help coordinate the teams, like calling the mothers, for example. That is something that can be done by an elderly nurse who doesn't have to come to the hospital. And the other thing we are doing is dividing the teams into groups so that this group doesn't meet that group. So that if you have one of your team is infected, then you can still run with the other team as the other team is recovering. Because unfortunately or fortunately, our mothers are still going to be giving us babies in the hospitals, and we need to serve them. And we cannot tell them that we are all sick. We have to be on the ground running. So we have to ensure that not everyone is on site. And we are starting to consider working in shifts, morning and afternoon shifts. We are starting to cohort the teams. And the interesting thing now about, particularly for Africa, the social dynamics are that you might be very successful at work in forming teams and shifts and everything, but then you discover in the social life of your staff members, they go to the same restaurants, the same pubs, or they live in the same apartments. So you also have, we have had to tell the staff members, for example, this afternoon, we had a general team Zoom meeting of all our over 60 staff members, where those who are sick with COVID were talking to those who are not sick, who are working, telling them the experiences and telling them how can you protect yourself and how can you protect the work that we do. The idea is to let them know, look, now this time around, the issues to do with privacy, as far as COVID is concerned, we might not have to do that, because if you're sick, we need to know so that we can isolate you and then let the others who are sick also isolate themselves. So finally, as I conclude, I think the biggest challenge or rather some of the opportunities we have identified are in starting to work with the health centers, which are still operational, and then starting to take our interventions at for example, the newborn unit. You're starting to use the birth registers. And what we do is we just go and ask them for their birth register. They keep a very good record of which baby was born by which mother, which is the mobile number. And then we can take that contact information, and then the people who are working from home because they're self-isolating, they can call these mothers. And then we have a team of research assistants, those who we are sure that they are not sick, combined together now with what we call in Malawi health surveillance assistants. These are like community health workers in other countries. These people now take the supplements to the multiple micronutrient powders to the mothers at home, because we also don't want them to come to the hospitals, because our health centers are not as advanced as other places. So we are also not sure when they come and crowd for the services, they could also get sick here. So also for ourselves, when we go to distribute multiple micronutrient powders, we have to take care that we don't become agents of COVID-19 distribution, of coronavirus distribution. So once we know you are clean, you don't have the virus, we give you the supplements, you go and take to the participants, and we try to facilitate the process through the transportation and the like. This is only possible because we are connected to the College of Medicine at the University of Malawi. I can only imagine those of my colleagues who are in more remote areas, the nightmare they are going through. So this is just my very tip of the iceberg contribution to this discussion. Thank you.
Wow, that's, I mean, thank you very much, Martin, for your contribution to hear that practical in the field experience. And I can relate with it because I'm based in Malawi as well. And maybe as, although in Nairobi right now, and maybe as you alluded, we've also had to have very practical ways of going around, or innovative ways of going around things that we had planned within our projects. And one of the things that, for example, Shola alluded to is the use of other services that are available. Because for us, for example, we were tasked with passing on nutrition information or nutrition education, and now there's physical distancing. And so what we discovered is, interestingly, mobile phone ownership in the very remote areas that we work in is much higher than radio ownership, but people use the mobile phones as radios. So now we are using the radio to pass on messages, and like you, we are using health surveillance assistants who have been trained on, the protocols to prevent from COVID-19 infection. So thank you very much for that. I think because of time, I will ask, I think time is far gone. I will ask Katie to give maybe some closing remarks. As you said, we could go on in this topic. It's very interesting, and people giving also their practical, ways in which they are handling these issues within programs and projects and so on. But let's keep talking to each other. What I would encourage before Katie and Shola give also final remarks is, in case you are interested in practical, for example, from what Martin shared, or Katie or Shola, you can be able directly to communicate that. I think Shola can put in her the Beth David's contacts in the chat box, and you can be able to now connect with each other and be able to have the conversation taken further. So Katie, I'll let you go first with your final remarks, and then Shola will close the session for us. Thank you.
Thank you, Wanjiku, and thank you to everybody for listening, and thank you to the Beth Davids International for the invitation to speak. I think the one thing that I would like to end off with is that we can learn lessons from previous pandemics and previous situations that we've seen. So if I take infant feeding and HIV, for example, we had a situation where mothers were discouraged to breastfeed if they were HIV positive. It had a spillover effect to HIV negative mothers. And we need to remember that the bulk of the population, our public health, the majority of the public do not have coronavirus, are not COVID-19 positive, number one. And number two, if we think about the infant feeding aspect and the risk of transmission through breast milk, a mother has just as much risk of transmitting coronavirus to a baby if she's feeding the baby a breast milk substitute as she is with breastfeeding, due to the respiratory hygiene, infection and prevention and control measures. So we need to be careful that we don't make the same mistakes that we've made in the past. And we do have epidemics like HIV, Ebola, and the Zika virus outbreaks where we can draw lessons from, and remember that we need to continue our routine public health interventions and key messages, and that I'm not just saying that the coronavirus pandemic is not serious. It is serious. It's a global pandemic, but that we need to make sure that we are promoting, protecting, and supporting optimal infant and young child feeding and maternal nutrition for the majority of the population. Thank you.
Thank you so much, Katie. Thank you so much, Wanjiku. And I just have to say a big thank you to Martin for providing that practical insight into what he's experiencing right now. But it something he said also showed that there is hope. And I just want to read something that Professor Marius Smarts actually put in the comments, that risk assessment and how we mitigate this risk are extremely important before implementing specific guidelines and recommendations and even interventions. And this we cannot overemphasize. So my take home today is let's keep this conversation alive. Let's not operate in silos and believe that, okay, nothing, there is a pandemic outside. Like Katie rightly said so many times, we can draw lessons from previous pandemics that has happened, and as much as possible, make sure that we don't, at the expense of the mothers and the future generation, we don't divert everything into what is happening immediately. We also have to think of the future and continue to take care of our pregnant women. Thank you so much to everyone that has been on this webinar. Thank you. It's been really enlightening and it's been really great. And at this stage, I say thank you. You can switch on your video to say hi, to say whatever it is, to say bye. I'm going to stop recording, but yeah, it would be so nice to see everyone's faces and just say hi. Thank you so much.
Thanks, Shola and Wanjiku.
You can unmute yourself and say something. If you can see Nancy is driving, don't unmute yourself.
Hi, yes, I was listening to you while I was dropping my son off at school. Thank you so much for the wonderful presentation.
Thanks,
so yeah, we were listening while we were getting ready for school. So we heard everything. Wonderful, wonderful presentation. Thank you so much to you both, and lovely to see you, Katie.
Great to see you too, Nancy.
Nice to see you all. Hi.
Hi, Gertrude. How are you?
Good. That was great.
Thank you very much.
Thank you.
Thanks for participating.
Okay. Hi.
Paula. Hi, Eva. Hi, Tokumbo. Hi, Patricia. Hi.
Thank you. Thank you for the great presentation.
You're welcome.
Thanks for attending. Thank you.
Thank you for attending. Thank you.
Hi. Say hello.
Hello, Shola.
Hello, Katie. My mom came. Dad. Hi, Mom.
Hello, Shola. How are you?
Very good.
God bless you, my dear.
Thank you.
Hello, Kati.
Hi, buddy. Nice to see you. And hi, Abra. I can see you as well.
Okay, thank you for the presentation. It was very enlightening.
Thanks very much for attending.
Okay.
Thank you.
Hello.
Hi, everyone. Hi, Katie.
Hi, how are you?
I'm good. How are you? This is Derek.
Yes, Derek, I can see you. It says iPhone.
Yeah.
iPhone Derek.
Yes, that's me. Thank you so much for the nice presentation.
Thank you for listening.
Yeah,
Derek is
thank
my
you.
fellow PhD colleague, PhD in public health colleague at UWC.
Yeah. Thank you, everyone. Bye.
Thanks, Derek. Bye.